Hi, my name is Paul Sethi. Today I'm going to talk about ACL or anterior cruciate ligament injuries. There are a lot of available talks and information about the ACL, and I think we're going to focus on just 4 specific topics. So if you bear with me till the end of the talk, I think we're going to point out some important differences. We're going to talk about the current concerns regarding ACL. Specifically, I'm going to get into some of the surgical improvements. One of our passions at ONS has been looking at post-operative pain, and we're going to talk about the reduction or the minimization of opiate medication after ACL surgery. And finally, we'll touch on some of the themes of rehabilitation and prevention. Clearly, we know that the ACL is a major issue. Over 250,000 ACL injuries occur per year. If we say it differently, looking at teen athletes, 1 in 10 athletes is going to have an ACL tear. Think about that. 3 players on your youth team may have this exact injury. The majority, again, is going to be in younger people. And we have a market increase that we noticed in the last 20 years with a focus because of increased sports participation, but really looking carefully, we're seeing a high increase in adolescents and particularly females. So let's get right into it. Let's talk right about the surgery. Well, ACL surgery, what do we do? Well, here's an image of a normal ACL. Then you can see images of torn ACLs. Here's a video of an ACL tearing where it's no longer attached to its socket on the femur. This is the injury. This is very clear on MRI. Often on the field we can make an assessment, and certainly in the office we have a pretty strong suspicion. So what do we do about this? How do we fix the ACL? Well, as it turns out, in most situations we don't fix the ACL. There are a rare subset of patients who are no longer playing high-end competitive sports at the collegiate or high school level, in whom we can repair it. And here you can see someone's ACL with 2 stitches placed into it. And what I'll do is I'll tighten it up, boom, right there. And in this rare subset of athletes who tear the ACL right off the bone, who are no longer playing competitive sport, we can do this. And this makes for a pretty fast and easy recovery. That said, the majority of athletes are going to have a reconstruction. A reconstruction simply means we're going to put a new ligament into where your ACL was, and that new ligament is going to serve as your new ACL. Where do we choose to get it from? Said broadly, we've got about 3 choices that we use routinely in the United States. A strip of your patella tendon right below your kneecap, or the patella tendon graft, is the most common graft that we will use in a collision or a contact athlete. The hamstring, making a small incision on the back of your knee, can also be a popular option. This is very popular in Asia and in Europe. I think in the United States it probably falls in second and maybe slowly going to 3rd place. It's a completely reasonable choice. And what we do in this picture, you can see this big, long hamstring that we harvest from the back of your knee, and we fold it over 4 times to make it into this strong cylindrical graft. Growing in popularity is the quadriceps tendon graft. Actually, it's been around for more than 20 years. When I was a resident at Yale, we were doing quadriceps tendon grafts. It's a very strong and robust piece of collagen, and it's very predictable. So sometimes in shorter or smaller athletes, the hamstring is going to be too short and not really acceptable, and here's a good use for the quadriceps tendon graft. It's even more useful in those athletes who are still growing, where we want to worry about your growth plates. Finally, I mention it because I think I'm compelled to talk about allografts. Allografts are donated tissue. You can see this unhappy face, and that's purely my opinion. Allografts can come from a number of different sources, but for me, and someone who takes care of a lot of athletes, I don't think allografts have a major role, with the exception of some unique setting. Here we go. What happens? I get this graft and I pull it into your tunnel. I'm looking into your knee. I've created a socket for where you're on the femur. I'm looking around at the knee. I've created a socket for where the ACL is going to go. So now I've got these 2 tunnels I've made, and I'm going to take this stitch or this wire and use that to load the ACL in there. And that's how it goes. That's how we build the ship in the bottle. It's pretty straightforward. It's actually very precise surgery. It's done with accuracy of millimeters and reproducibility of millimeters. So we're very happy about it. Final look, what's it look like? Here's what this ACL looks like. You can reach in and you can probe it and feel it. And this is a nice, strong, rigid graft. You can't really sort of pull it out of the way, and it really restores the stability of the knee in a predictable fashion. But wait a second. We talk about all these ACLs and we talk about how good the results are. And I think somewhere in the early 2000s, we would cite repair success rates of 96%. But if you take a little more careful look, particularly at the female athlete, we may have some trouble. In a study that just came out in 2021, looking specifically at female soccer players, 68% had a new knee injury. 42%, nearly half, had a second ACL injury. And there was a 4 times higher risk. So wait a minute. This is a big problem. Close to 70% of female athletes are having additional surgery after their ACL within 5 years. This isn't just one European study. As it turns out, when we look back in the literature just a few years before, we see 30% of athletes having a second ACL injury. So we really need to stop and say, gosh, are there things we need to do differently? Are there things that we can do to make the first event even better? Can we make athletes return back to sports at a higher rate? And as it turns out, we believe we can. The outside of the knee, the lateral side of the knee, is a site of additional reconstruction. So we're now thinking about adding a second procedure to your ACL. The ACL goes within the knee on the lateral side of the knee, and there's 2 different techniques. We can talk about a Lemaire technique, which is taking some of your own iliotibial band, or we can talk about an ALL, or an anterolateral ligament. Neither of these are actually brand new techniques. They've been around for a long time, and they revisit some of the things we learned many years ago in the ACL. But what we realize now is that in certain athletes, we're going to want to add an additional lateral procedure. Here's a video of a Lemaire that I recently did. And what you can see here is the lateral side of the knee. I'm showing you the iliotibial band. I'm going to slide underneath the lateral collateral ligament and attach it just posterior to the lateral collateral attachment. So I make a small incision on the lateral aspect of the knee, and I'm going to take a strip of the iliotibial band. That iliotibial band, I'll bring it all the way down towards the tibia and release some of the fascial adhesions towards the bone, but I'm maintaining that attachment. Here you can see I've slid underneath the lateral collateral ligament. That's the lateral collateral ligament that you can see right over there. And I'm going to take the iliotibial band and I'm going to run it underneath the lateral collateral ligament. I've whipped up, or I'm suturing the iliotibial band so that I can control it. Here it is. It's going to go in and around the lateral collateral ligament. So it gets shuttled underneath the lateral collateral ligament and it gets pulled over. And this is going to be your extra buckle laterally. Now I have to fix the iliotibial band on the femur. And I'm going to use a screw or a washer, or I'm going to use an anchor. I have a lot of choices. And in this case, I'm going to bring it down into this very small device. As we talk about the surgical nuances, it's actually pretty straightforward on how to miss or avoid your ACL tunnel, so you can do these surgeries together. And once again, I'm going to tie this down into place and get a really strong fixation. When I do a Lemaire, I'm going to do it in a little bit of additional knee flexion as compared to an anterolateral ligament. Here I'll sew it together, take off the excess, and then do my final tensioning. And I think we can get this Lemaire down to about a 5-centimeter incision. And you can see that there's no inhibition of range of motion. So that's a very nice technique for revision ACL surgery and reducing the rate of reoperation. In a slightly different way, we're going to look at the anterolateral ligament. And now you can see through 2 percutaneous holes what I'll do here. I'm going to put a shuttling stitch over onto the femur. I'm going to affix, in this case, an allograft. I can use allografts on the lateral side of the knee, but not intra-articularly. I'm going to affix the graft onto the femur. I'll shuttle it through and get it onto the tibia. And here you can see I'm looking up the femoral tunnel where the ACL is going to go to make sure I don't converge or hit my tunnel. And I'm going to fix the ALL down on the knee at a point between the fibular head and Gerdy's tubercle. And I can sew it into place, and that's it, and through 2 small incisions. So look, I went through a lot of information, but really what I'm trying to get at here is that we have to look at certain athletes, and we have to understand who is going to benefit from an ALL or a lateral extra-articular tenodesis. In one study, the reduction rate went from 11 to 4, so almost a third of the injuries. And in the second study, graft rupture rates were actually cut by 2 to 3-fold when we look specifically at adding an ALL. So I think we need to think about this in young athletes. We need to think about this in high-level pivoting athletes, female athletes who are a high rotational grade instability, hyperlaxity, and also with meniscal repair. The last part I want to talk about for the last 2 minutes is pain management, and this is a specific focus on the minimization of opiates after surgery. We have a very specific multimodal plan that includes specifically anti-inflammatory, Tylenol, neuromodulating medications, as well as an effective nerve block. What we've seen, and this is actually really amazing data, we look at patients over the post-operative experience, and their pain scores after surgery don't get above or 2 or 3. We have close to 55% of patients taking no opiates after ACL surgery, and just about no one who's going to use more than 12 pills. Part of the goal is getting early physical therapy to limit the effusion, restore their range of motion, to regain their strength, to get them weight bearing early. We're going to start to use BFR, or blood flow resistance, so that you can now stimulate the muscles locally and centrally. We're going to look at ACL prevention programs and really avoid, as you return to sports, landing with knocked knees like you can see in this picture. You want to land with squared out knees in a strong core gluteal mechanism. And finally, we're going to have all of our athletes, whether they're soccer players or not, work on the FIFA 11 program as part of their own home training protocol. So, to wrap it all up, when you tear your ACL, it's an imperfect event, but we believe we can get you back to sports. For athletes, we believe that autografts, your own tissue, is substantially advantageous when compared to allografts. For high-risk athletes, I've shown you 2 videos of lateral procedures that I believe can reduce the injury rate in revisions and the athlete at risk. Post-operative pain does not have to be a major concern. We can get you through this. We don't have to be opiate dependent in a very vulnerable group. And early physical therapy is critical to recovery. Thank you very much for your time today.